Well, welcome everyone to our program, a virtual town hall, colorectal cancer in the time of COVID-19. I'm so grateful that you have been able to join. We're right now making the event live on Facebook, so if you are connected through Facebook, you can share it out for other people who you think may benefit from joining. I also want to let you know that the program will be recorded so that you can also share out the recording post-program. So I'm Sarah Louden from Total Health Conferencing, and I'll be your moderator for today. I do want to go around the room and just give some quick introductions and then an overview of the agenda and how the program will flesh out between now and the end. So we will start with an interview with advocacy leaders, and we're so honored to be joined by probably three of the most important and impactful colorectal cancer advocacy groups available. We have Steve Schwartz, who's the mayor of Colontown. We have Sharon Worrell, Senior Patient Education Manager for Fight Colorectal Cancer. And Andrea Goodman, VP of Patient and Family Support from the Colorectal Cancer Alliance. We will then move on into a section for an interview with medical leaders. We have Dr. Gregory Botta, Associate Professor of Medicine from the University of California, San Diego. We have Dr. Scott Kopetz, Professor of Medicine from MD Anderson. And we have Dr. Aparna Parikh, Assistant Professor from Massachusetts General Hospital. We'll then be joined by the medical director for a company called Natera, who will speak to us about an assay called Signatera. And then finally, we'll wrap up with an amazing patient testimonial by Angela G., who will share her experience with using Signatera and also just being a patient and all the concerns around that during this unprecedented and very uncertain time. So I'd like to ask my team, Dalen Miller and Raina Wilhelm, also to help with moderating some of the questions that will be live on the chat room, as well as some of the questions live on the Facebook. Please feel free at any time to be sending these questions. Once we get them, we will filter through them and make sure that we present them to our team of experts that we're joined by today. So we're going to move right into the interview with advocacy leaders. Again, we've got Fight Colorectal Cancer, Colontown, and the Colorectal Cancer Alliance with us. And as we adjust the screen so that we are now looking only at the people that we're interviewing, I'd like to just start by asking, in order, each member to tell me a little bit about your organization. So Steve, I'm going to start with you. Tell me a little bit about Colontown, if you would.
Sure. Thanks for inviting us to participate. Colontown is a online international community of about 5,000, more than 5,000 CRC patients and caregivers around the world. And really our main goal is to empower patients. And the ways in which we try to do that are to, number one, provide social and emotional support for people who are traveling down the same path, and also to try to enhance the health literacy of patients and caregivers, whether that means information about treatments or symptom management or clinical trials. We really place a premium on trying to help patients and caregivers have access to high quality, well-vetted scientific information that can help them make sound decisions in conjunction with their oncologist. Colontown's basically made up of it's a fully online Facebook platform community that is made up or sort of composed of roughly 140 different private Facebook neighborhoods. Each of them has a patient or caregiver who's an administrator of that group, and they're organized in all manner of ways. We have some groups that are organized around disease stage. So like I'm a stage 4 CRC patient, so I'm in a group called Four Corners. We also have a bunch of organ-specific groups that focus on local regional treatments. So that entire community is called Mets Stadium for metastases, and then we've got groups like Liver Lovers Lane and Lungston for folks who are talking about treatments related to those. We have about 40 local crews that help people who live in the same geographic area to connect. So we have a Motor City group for Detroit. We have a couple of international groups. We have a group for patients who are under 40 that are addressing early onset issues. And then we have several care partner groups, as well as 10 groups that focus on clinical trials, both the science and emerging treatments, as well as kind of the logistics of getting on trials.
Very good. I have experience with visiting some of the Colontown communities, and I think probably one of the most powerful things about Colontown is that you really do get to identify with a group that looks and feels like you. So while you have kind of larger umbrella organizations like Fight Colorectal Cancer and CCA, Colontown really has done such a great job in I love how you say it, helping people find their people. I really love that, because I think that that's so important on this journey, that what I'm experiencing, even if it looks the same stage-wise, may not be the same thing someone else in a different, walk of life or different age group or whatever is experiencing. So I really love the way you have divided the community so that it really feels like you can find those people. Sharon, can you talk a little bit about your organization?
Sure, of course. Hi, everyone, and thank you for having Fight CRC here for this conference. So Fight CRC, I mean, we're a group of relentless champions for hope for all people that are affected by colorectal cancer. So colorectal cancer patients, survivors, their families, their loved ones. This disease touches, a lot of people. And so how we champion is through informed patient support that's both balanced and objective. We strive to make impactful policy change, and so that's in part by equipping and empowering advocates themselves to influence legislation and policy for the collective good. And then, of course, we focus on breakthrough high-impact research endeavors. And so that's through our research advocacy training and support programs, where we train patients and survivors and loved ones how to share the patient perspective in the research world. And then we also convene expert working groups around immunotherapy for colorectal cancer and early age onset colorectal cancer. And then, of course, through funding research itself. So we do a lot of things really trying to meet patients and survivors and caregivers where they are, both on the trajectory of illness and disease, but also where they are in terms of, the society impacts on patients. And I know we'll talk about that a little bit more in terms of what's going on right now with COVID-19, but, there's a lot of different influences in addition to the cancer itself that need to be taken into account. And that's a lot of what we focus on as well.
Well, thank you for sharing that. I recently was at a medical conference in Memphis where we organized around doing this Strongarm Selfie. In fact, I think Natera was a sponsor of providing all the patients these shirts that said fighter at the front. And so we had all the doctors that were part of the conference, give their Strongarm Selfie. And one of the patient advocates for a big oncology clinic there, when we were talking about, how do you engage with patient advocacy organizations, as she was describing Fight Colorectal Cancer, she said that you all embody the Strongarm Selfie because you give people the platform to be fighters, where they may feel like, okay, I have this disease, now I'm managing my treatment, what can I do? And she said that you all give the platform to be able to allow people to kind of activate So I really love that it's part of the name of the organization, and it's definitely part of your mission as you've just described it. Andrea, can you share a little about the Colorectal Cancer Alliance?
Yeah, thanks, Sarah. Thanks again for having us. I'm really soaking in the opportunity, this one and others, to really collaborate across our organizations right now as we're all trying to figure out, how to navigate this with our patient communities. So let me tell you a little bit about the Alliance. We're the largest colorectal cancer advocacy community and have been around for more than 20 years now. Our mission is to empower. I've heard a lot of us already using the word empower. Of course, that's critical to all the work that we're doing, but really to empower our ally community. And we do that through 3 core pillars, we call them. Screen, care, and cure. Not surprisingly, those are our 3 focus areas. So screen, of course, focused on early detection, prevention, and making sure that we support access generally to screening for anyone in need, critical to our population. Care, which is really my core area and arguably the most important to our conversation today and helping our community navigate COVID-19, is really about supporting our community through all of the various needs, not just for patients, but throughout the survivorship journey for caregivers and others around them. And then cure, of course, focused on research, because we really do believe that we can end this disease in our lifetime. So we invest in research internally. We support the research community towards advancements in learning that we apply back to our community and make sure that that information is fully available and digestible to anyone who needs it. We also have a new clinical trial finder available to patients and families as they navigate how to access clinical trials that apply to their profile, and we follow that up with navigation through our certified patient and family navigators on the phone and online, and I can talk a little bit more in a bit about how we're expanding that right now.
Well, thank you so much for letting us know the power behind CCA. I think it's really undeniable that as you use the establishment of how long you've been, in the field of advocacy to then advance things like, clinical trials. I think that that's such an incredible part that, again, when patients are first diagnosed, they're not thinking about, are there clinical trial options available to me? And so for them to be able to get connected to an organization that not only alerts them to the opportunity to be on trials, but then can help them sort through and find applicable trials and then have someone work with them all the way through. I mean, it's invaluable not only to the patient, but to the field of colorectal cancer and other GI cancers. So I think it's just so impressive. And I love too, I hope that everyone viewing can see really the power of these 3 individual organizations, but the power of them working together in collaboration. And as we go through and to get to know each other a little bit more during this session, I think that you'll see a lot more of that shining through. So Steve, back to you. What are you doing right now as an organization to be a resource for people impacted with colorectal cancer? Steve, I have you on mute.
How's that?
Yes, perfect.
Yeah, the new normal. So yeah, my day job is to teach communication, and to me, one of the things that has always fascinated me about Colontown is the way that so many of its members really take advantage of what's best about social media. I mean, social media can be a real morass, but it also, opens up some great possibilities. And, I tend to think of Colontown as trying to offer the best of what social media can afford. And there's really 2 big things that we do with respect to, what's been happening recently. One is, of course, is taking advantage of sharing personal experiences and stories. And so in all of our communities, there is a lot of talk going on about how people's treatment patterns are changing. Should I get my next infusion? What are the risks of going into the clinic? And so, a lot of those conversations between patients and patients talking to their oncologists, and then kind of debriefing it with other patients. That's one really important thing, is kind of understand what the lay of the land is for people who may be feeling isolated or not at a major center. They can really benefit from that. The other thing that we are continuing to do, and I think is helpful in this moment, is sharing expert perspectives on cancer treatment in the age of COVID. So we had a webinar with Dr. Gregory a couple of weeks ago that was quite helpful. We share a lot of the videos and podcasts from other doctors that are talking about, how they're adapting to the moment. We share tweets and articles that help to explain and interpret a lot of the studies that are taking place, because our patients want to know as much about COVID and the emerging treatments for that as they do their own cancer treatment. So it's really those two big things around sharing information, sharing perspectives, and facilitating discussion among people that are traveling the same path.
Yes, and you do it so well. It's always what you've done. Now you just have new vehicles to do it. So I love that. Sharon, how about you? How is Fight Colorectal Cancer kind of morphing to continue to be a resource now where, times are so different?
Sure. Yeah. So I think, like, to echo what Steve was saying, we've had to shift a lot, using the tools that we have as an organization that already, uses a lot of online platforms. All of our in-person events for the year have been shifted to online events, so similar to this kind of a format, so that we can still engage with our community real time and have these meaningful events continue to occur. We also have been calling on our medical advisory board and medical experts to help share the opinions and updates of what's happening. We were able to interview Dr. Al Benson, who is actually on that NCCN task force for colon and rectal cancers, helping to devise the guidelines for treating colorectal cancer patients in the time of COVID-19. So I think having a medical advisory board, we work closely with Dr. Scott Kopetz as well, to make sure that patients and advocates have the most up-to-date and accurate information. So that's a lot of what we're focusing on there. Additionally, as an org, we've always supported the psychosocial well-being of the community. So highlighting our resources around mental health and putting those into the context of social distancing. How can we continue to maintain our well-being when we're there's stay-at-home initiatives and this type of thing. So we've developed a new program, Wellness Wednesday, that is live streamed on Facebook every Wednesday morning at 8 a.m. Pacific time, and we have a range of experts, patient advocates, survivors, people that are really passionate about healthy lifestyle and that type of thing. And it's a way for people to connect and kind of get little tips about things that might help maintain levels of positive mental health and behavioral change and that type of thing. So just really trying to meet people where they're at right now and make sure folks have up-to-date information, that they have resources to turn to. We've also been doing a lot of work around educating around what does it mean to be immunocompromised, and
Yes.
how do patients talk to their friends and family about what that means. So we've been tackling it from a number of different angles. I'll end just by saying that our policy team is really working to understand issues around coverage. For instance, if a patient lost coverage or their family member lost coverage, what's the experience right now with FMLA? Discussions around, home infusion and increasing access and, safety standards. There's a whole other area of focus that our organization is working on in terms of policy. But in terms of, education and meeting the patient where they're at there, a lot of it is around, the information, psychosocial health and well-being, and
Sure.
staying connected.
And, you mentioned that you've had to make a lot of your live activities virtual.
Yeah.
And I know that it probably is across the board with all three, Colontown, Colon Cancer Alliance, and Fight Colorectal. As you can imagine, it is for a conferencing company that specializes in medical education. So we're all kind of in the same boat with trying to still deliver impactful information to audiences who we know need it, but then to be sensitive to the fact that there will become times where there's virtual fatigue, and there's 900 different options of what to do with a Saturday afternoon, or that because people are working from home, they're zoomed out. How do you think that it's going to, and Sharon, I'll start with you, and then we'll hear a little bit more about how Colorectal Cancer Alliance is morphing, but then I'd like to ask across the board, how do you think that the absence of the ability for kind of the human beings to connect physically, how do you think that has an impact on overall growing advocacy? Do you think that we will be able to replace some of what we're doing with virtual?
Sure. So, I don't know for sure. I mean, I don't really think that there's any replacement for being able to be in person and, storm Capitol Hill and like that feeling of like being physically with people. But with that said, there are ways to be involved online. There's a number of ways to be involved, if you're talking about policy change and having your voice heard that way through emailing and letters and engaging in that way. And, Colontown is the perfect example of how you can engage with people, like real people, real time, and feel that sense of connection. So I think, I don't know if it's necessarily a replacement, but I do think that the same levels of achievement can be made.
Well, thank you for that. Andrea, talk to me a little bit about how you're continuing to be a resource, and then maybe, follow up on the virtual versus physical connections that we feel when we are gathering together live.
Yeah, sure. It's a hard one. And I would say in answer to both of those, the first thing we did when we realized that all of us realized that this was happening and going to impact all of us in our community so significantly, and started to think about how to pivot the tools that we already have in place to make them work in this context, in this environment, was to really listen to our community. I mean, it is our role to show up in whatever way makes sense for our patients and caregivers and other partners during all times. But it took a little bit of humility to sit back and say, this is new for all of us. What does our community really need, and how can we best serve you? And I think that will be an ongoing process. I mean, we have stood up some things that I'll tell you about, but we will have to keep asking the question. I think we will all have to continue to answer the question, and it will evolve over time. And so some of the solutions around in-person gathering and really formalizing and feeling like a part of a community is going to have to evolve over time as we're all continuing to work with what we have. So as we've been listening over the last few weeks at the Alliance, we've heard, and I really echo the comments already from Steve and Sharon, the main needs and desires and fears that have come out of our community are around, one, financial toxicity. So anxieties and fears and realities around finances and medical care and costs, et cetera, have magnified, not surprisingly to any of us. And so we immediately stood up a crisis financial aid fund that is available right now for patients in treatment. And I see we've already received some questions, Sarah, and I know you'll be sending out.
Yes.
Just to let everyone listening know that this information will be sent out by email afterwards. Is that?
Yes, yes.
Okay,
Yes.
So we have, in there will be information about all the things I'm talking about. So we have this crisis financial aid fund for patients in treatment who can apply now. We've also received, as Steve and Sharon talked about, there's a lot of questions and confusions and information needs that we are all asking every day about how to navigate COVID-19 as a condition, what it means for immunocompromised patients. How do you know if you're immunocompromised? How do I make decisions about the risk versus benefit of getting care? Those are very real questions, and the answer changes daily. And so as advocacy communities, it is absolutely our role to be the trusted informant. We're not always the initial supplier of that information. So we also look to the medical community, but we are the trusted source. So we have a coronavirus webpage on ccalliance.org where we are updating information daily. We send a patient newsletter that has access to all of the information that you would need, including our own resources, and we make that available on our helpline, which is answered Monday through Friday, 9 to 5. So that is how we are solving, for now, as much as we can, kind of the confusion and medical question need. And then the other biggie, of course, that has already been talked about is around connection. And in lieu of in-person anything, how can we make sure that all of us have access to connection with other people, with the community? How can we obtain peer support? How can we help around the loneliness that a lot of us are feeling at home, but especially some of our patients who are now going into medical institutions alone without their caregiver who they're used to having as they sit in the chair. And so we've deployed our online community as well. We stood up a new group chat that we now have twice a week, in a group online chat around COVID and any related conversation. We have an ally social hour on Fridays at the end of the workday that has been really popular. And of course, our kind of legacy buddy program, I think, becomes even more critical now so that everyone has somebody that they can go to. And we'll be continuing to kind of add on to those programs as needed throughout this crisis period.
Thank you. Thank you. I mean, it's really incredible to see. And I think that, again, is the power of making sure that all the stakeholders that are involved in supporting a patient from diagnosis through treatment into survivorship, all the stakeholders work together, because as we'll hear in the next segment, as the medical experts kind of started to pivot with what do we need to be able to provide patients continuity of care, advocates were asking all the questions. Well, what about the human factors? You know, the fear, the anxiety, everything that's going on financially. And I mean, one of the things that you said that I still, it causes me to struggle so much is the loneliness. I mean, as you can imagine, we have a lot of, you know, friends in clinical practice, and I think overwhelmingly that's on even the physician side or the nurse side. That's probably one of the hardest things, whether you're physically able to connect with your patient, meaning you are face-to-face in a room, or whether you're doing telemedical visits. The typical hugs, the typical hand holdings, all of those things they're stopped, they're blocked for this moment. And so I do think that letting patients know that you're not alone, that maybe you're going to be going into your visit by yourself, but by no means are you alone, is something that helps people get through, you know, these challenging times more effectively. So thank you so much for sharing some of the resources that you have available. Steve, do you find that COVID-19 and just this new normal that we're all experiencing has strengthened the way the Colontown citizens engage with each other?
It's definitely heightened the importance and intensity of it. I don't know if I can say it's gotten better or worse, but it's yeah, I think it's, you know, it's definitely fueled a lot of great conversations. Certainly in our group, we've tried to do our level best. I mean, we're all living in the Zoom. The age of COVID seems to be the age of Zoom, and so we're using Zoom to help We've had a couple of sort of town hall type open meetings, as well as some of our smaller neighborhoods have had meetings that way to help stay connected. And certainly for a predominantly online community like Colontown is, it's keeping those personal connections going are really what helps sustain you in difficult times. And so even before all this happened, that is, that's one of the things that attracted me and has kept me involved in Colontown, because you can see that social support taking place, even if it's on a screen. So again, in some ways, our ability to take advantage of that platform is something that we're trying to carry forward. The other way in which we're sort of trying to retool a little bit and shift things is that we're in conjunction with Phi CRC, we've been working on a trial navigators program to help train other patients how to be effective peer navigators, specifically in the context of helping people learn to navigate the clinical trial world. So in early March, we were scheduled to do a workshop in DC that was going to bring everybody in, and as things became more clear that we couldn't do that, we had some tough conversations about whether we were going to continue with that program or not, and ultimately decided that we needed to postpone having a face-to-face workshop. And over the past several weeks since then, we've been thinking about how we can use this moment and use other online tools and platforms to still do that kind of training. So that's a work in progress for us right now. We're aiming to launch it right around the time of ASCO. But for me, at least, it's helped me realize that, I love the face-to-face interactions I've had. I know that the first leadership workshop that I attended as part of Colontown, that was as important as any of the content that I got about how to run a group. It was being able to meet these people who I had only interacted with online. I'm sure every organization is with that. And so as important as those are, it has also helped me think that, these kind of one-off events need to be sort of moved into how you can maintain programs when, especially for the long haul, for the indefinite future, so many of our patients are not going to want to travel. Right?
Yeah.
They're not going to want to get on a plane. They're not going to want to go to a different community because of being immunocompromised, or for whatever reason they decide that that's not the right thing for them to do. So we're recognizing that, this is more than just sort of a short-term blip in how we will need to engage patients and build out programs and provide for our community.
Yeah. I love that, that's an example of Colontown working with Phi CRC, two organizations getting together, seeing a need, and mobilizing to develop these kind of peer-to-peer training programs so that you're developing new advocates, people that are able to kind of go out there informed and help their fellow community. And Steve, I think you're right. Maybe the question that I asked wasn't the right question. Do you think, you're growing stronger in interaction? I think when any patient finds themselves in this new position of a new diagnosis, or maybe they're starting their treatment, you talk to your husband, you talk to your wife, you talk to your sister, your mom, your kid, your friend who had a diagnosis a couple of years ago, someone who has a diagnosis but is in a different tumor type. And there's always like a little bit of empathy, but when you get on a chat board, and you start to see and hear patients that look and sound exactly like you, and that are answering the questions that are in your head and your heart, but have no one to question, and you start to see you're not alone, your questions aren't, unique, you're not operating in this isolation, I think right away it unlocks the power of friendship in a way that you don't even really recognize as the typical friendship. Someone you've never met that lives across the country, maybe in a different time zone, you're posting something and you're waiting for their reply, and they're posting something, and then you're DMing each other, and it's like you have now just joined together in such a significant way. So I feel like what Colontown does to provide a platform where in real time I could get on and post I'm scared, or tomorrow is the first time I'm going in since all this started for a blood draw, or any of the things that you're experiencing as a patient. And right away in your communities, people say, me too, or did that last week, or I was scared too, don't worry, it's good, make sure you wear your mask. I feel like those are the things that matter in real time. And going back to what Sharon and Andrea shared about what Fight CRC and CCA are doing, the common denominator is that you are meeting people where they are, and you're meeting people not just where they are, but with what they need. And sometimes we as patients don't even know what we need until someone says, have you considered X, Y, or Z? And here you all are providing those resources in very different ways, but all that complement the journey that the patient is going through with their diagnosis and their subsequent therapies. So we're coming to an end. We've got about 5 more minutes. So if each of you can spend about 1.5 minutes just with a personal takeaway of how being in advocacy, being an advocate, maybe a story about how someone who you've seen tap into advocacy resources, just a testimony about that, especially at this time. And Andrea, I'm going to start with you.
Sure. Thanks for asking that question, Sarah. Gosh, we're all learning so much during this time. It's really been an important challenge for us, I think, as people, as a community, and of course for our patients. I would say some of the biggest takeaways for us right now as an organization, and I think broadly for our community, are around flexibility and transparency, and really that humility that I think I mentioned earlier. It is hard to realize that we cannot solve all of these problems for our patients. We are hearing very real stories of fear and sometimes outcomes that we can't control. But the resilience of our community has come through loud and clear, and we are going to continue to pivot and be flexible to meet those needs and meet people where they are, as you said, Sarah. I think that is the most important thing we can do right now. And it's not just us as an organization and the work we're doing as professionals. Our people, our constituents are doing it on their own, really. We're giving a platform and tools for people to connect. And, you know, the power of connection between peers, and the example you gave of, you know, the communities are talking to each other and people are able to find answers within themselves and for each other. And really standing up and supporting each other in that way, I think, is going to get us through during this time. So making sure that we utilize the kind of collective voice in a way that we always have, but obviously in this new environment, I think is going to be the real solution for us here.
Yes, yes, thank you. Sharon, can you share a testimony or a takeaway?
Sure. Yeah. So, I mean, I think things like this coming together across organizations to share, you know, how each one can be effective in supporting the patient communities. I mean, these types of things are really important to highlight that work. I think, you know, keeping the communication open with advocates and the patient community is huge. And I think Andrea talked about this really well. It's like we listen, like we are here to listen to your stories. And really, it's not us leading the way. It's patients telling us what they need, and how can we as organizations really carry that out on their behalf, and make sure that, you know, the patient community has what they need at this time, and also really supporting. You know, it's a difficult time with, you know, the pandemic, and people are still being diagnosed with colorectal cancer on top of this. And so how can we continue to meet those people that are both living in this you know, situation along with all of us, and they've just received a colorectal cancer diagnosis. So making sure that we continue to push those resources as well, like next steps in terms of, you know, putting your treatment team and what treatments might you expect to talk about with your care team. And all of those things also are incredibly valuable. I think having a lot of unknowns right now is really difficult for everyone, right? You know, patient community, caregivers, organizations, doctors. I think we're all in this. I mean, you hear the term all in this together. And I think just having that sense of unknown and really, you know, leaning on each other to get accurate information, to find support. You know, I think all those things are really critical. Yeah, I'll end there, but thank you.
Yeah, no, I agree with so much of what you said. And, you know, you're so right that the feeling, the consensus and the culture is that we really are all in this together. I mean, as much as everyone feels sad or lonely or the anxiety for a new diagnosis, or a recurrence, you know, you're thinking everything's fine and then you have a recurrence and then it's like, oh my goodness, everything's starting back again with the knowledge of what happened the first time around. Now it's going to be a totally unrecognizable setting. So I think you're absolutely right that we do have to remind ourselves, as hard as it is to feel because we don't feel physically together, that we really are all in this together, and that there are resources, you know, resources and organizations and advocacy and medical, all those things are words, but as humans, we're all in this together. And, you know, each one of us are looking for opportunities to help one another in ways that are meaningful. So I do agree with everything you said. Steve, can you close us off with the advocacy session of a takeaway or a testimony for how you think advocacy has really kind of been highlighted during this time?
Sure. I mean, I could take this a zillion different ways. I mean, I would want to, you know, echo one thing that Sharon is pointing out about uncertainty, right? I mean, for me, I mean, I'm 4 years into my diagnosis, and that still is kind of one of the biggest challenges that I personally face is dealing with the uncertainty. And on the one hand, people and, you know, patients in our boat, we're used to dealing with that. We get it, but then having this extra layer on top of it is really challenging for a lot of our patients. With respect to the clinical trial world, you know, several of our patients have been really good advocates for this. Renee Roach, one of our community members, was in an NPR story last weekend talking about the challenges of getting into a clinical trial. And we've had a lot of discussion in our clinical trial groups about access and whether trials are not taking new patients, or how things on trials are going for them. And I think hopefully one of the things that it is starting to raise in discussion, both among patients and in the larger medical community, is whether this scenario raises the possibility of making trials perhaps more flexible and more accommodating to patients, so that they can, you know, both so we can see an increase in enrollment and so that they can continue forward with those trials. I know that someone living in a rural area, trying to get access to trials can be very difficult. And so the more that there's some other avenues or venues for allowing people to participate in those trials, I think is all the better. So that I'm kind of sick of the silver lining metaphor. I don't see a lot of silver linings, but I think the more discussion and communication we can have about some of these issues, you know, hopefully can help to alter things for the better of the long term.
Yes, yes. Well, Steve, Sharon, and Andrea, it has been incredible to have you featured first. I think, you know, when we talk about cancer as a whole, and then talk about colorectal cancer or GI cancers, so many times we just jump right in, especially coming from a medical education perspective, we jump right into data and, you know, side effects and all these things. And we don't often start with putting the patient perspective first. And, you know, to disagree a little with Steve, I love the silver lining metaphors at this time. I kind of live for them at this time, but I feel the silver lining in this is that because we're all kind of normalized to all being a potential patient of COVID-19, the reality that each one of us are not immortal and are not in a position, whether you're a physician, a nurse, et cetera, and we'll hear in the next session because one of our doctors actually had COVID-19, it brings around everything that we do to make us say, we really are doing this for the patient and the patient's voice should be in this. So I feel that having Colontown Fight Colorectal Cancer and the Colorectal Cancer Alliance not just participate in this, but launch this town hall was an important part of starting to change the conversation where we do always start with the patient first. So I thank you all for sharing. I invite you to stay on. I'm going to ask my team to now transition into the medical experts, and in a little while, there's a few questions on the Q&A. Any of you can feel free to share resources and information directly onto that Q&A while we transition, and then we'll have a live Q&A at the end of the town hall. Thank you again to the three of you. Dalen, I'd like to ask you to invite the medical experts to share their videos. Wonderful. Okay, hello. I hope that all of you enjoyed that opening interview with patient advocacy groups. I think that all of us who sit squarely in medical practice often think of advocacy groups as more of a resource, and here they are being kind of the primary source of information where patients are going to get information now that they're restricted from seeing you. So I think that it has highlighted the power and importance of patient advocacy groups. All right, so I'd like to get right into it. Again, for those who are joining us a little bit late, I'm here interviewing for our COVID town hall on colorectal cancer, Dr. Gregory Botta, Assistant Professor of Medicine from the University of California, San Diego, Dr. Scott Kopetz, Professor of Medicine from MD Anderson, and Dr. Aparna Parikh, Assistant Professor from Massachusetts General Hospital. Welcome to the three of you, and thank you so much for joining. I'd like to just ask each one of you to introduce yourself, and because I'm very chivalrous, I will say ladies first. Dr. Parikh, if you would introduce yourself.
Yeah, thanks so much for having me. It's really a pleasure to be here with the advocacy community and Alex and Sarah and the team. So I'm Bada Parikh. I'm a gastrointestinal oncologist at MGH. We primarily see colon cancer and pancreatic cancer too. Do a lot of our clinical trials. Have been pretty actively involved in our liquid biopsy efforts as well. I'm happy to sort of share the COVID relevant experience in the upcoming segment, but actually did have COVID-19 now over a month ago, and have been traversing two worlds. I'm still maintaining my active clinical oncology practice, but given the volume of patients that we had at MGH, there's about 30 oncologists who have been deployed to the floors as well. So I just spent my first week on a COVID-19 medicine.
Dr. Parikh, I just want to interrupt you because I'm having some feedback that maybe your volume is a little bit too low. Is there a way you can either sit closer to the mic?
Sure. Is that a little bit better?
Yes, much better.
Yeah, so maintaining a busy clinical oncology practice, but have been in a group of 30 oncologists or so that have been deployed to cover overflow surge units, including ICUs, for the next sort of 2 months at least. And so my husband is a pulmonary critical care intensivist doctor. So, this is very much, an everyday part of our lives as it is for everyone. So have experience from the caregiver end and spouse end and patient end and all of those, and obviously oncologist end too. So happy to answer questions going forward on what it's looking like for us.
Thank you very much. Dr. Botta?
Hi, I'm Gregg Dada. I'm a gastrointestinal medical oncologist at the University of California, San Diego. I see patients in the GI oncology division, colorectal cancer patients, pancreas patients as well, and also run a lab evaluating different ways of targeting tumors in a fashion that enables us to have low toxicities, but able to improve chemotherapies and targeted therapies. Very interested in the molecular diagnosis of cancer, as well as the therapies that we can apply towards that. Have definitely been involved in the COVID response at UCSD, where we practice and setting up ways of allowing our patients to get in and be tested and decrease risk. My wife and I, she is a nurse practitioner in palliative care, have been impacted by this and have been working through it with our patients, both newly diagnosed and at the end of life.
Thank you. Thank you. Dr. Kopetz?
Hi, thanks. And thanks for the opportunity to participate today. So my name is Scott Kopetz, likewise a colorectal medical oncologist here at MD Anderson, both working in clinical trial research as well as lab-based research as well. And I think like Aparna and Gregory, really dealing with both managing patients as outpatients as well as kind of the patients that are getting diagnosed with COVID and coming in. And so I'm actually in the hospital today and saw 3 new patients that came in overnight with COVID and just getting notices there's 2 more waiting to be seen after this. So I think, in Texas, I think we're at the point where we're still on the up climb and still not quite sure where the peak's going to be in the midst of this. And so I think kind of share a lot of the uncertainty that you've heard already.
Thank you. Well, on behalf of everyone on the call and everyone who's watching from Facebook and everyone that'll watch when we rebroadcast, I just want to say thank you to all of you for what you're doing, especially in seeing that 2 of you have, and I don't know, Scott, if you do too, but 2 of you have your spouses who are in the field as well. So I just thank you so much for what you're doing, because it's got to be so hard. You're dealing with the same things that all of us are dealing with the new virtual reality of being on meetings and tumor boards and educational programs, as well as homeschooling teenagers and little ones and being connected to your children and still managing not just your cancer patients, but now in this whole new world of, being asked to be on service for things that, you haven't done since training. So I thank you, and I think that it's, echoed throughout. Aparna, I would love to just get in with you about your medical perspective of COVID-19, not just from a physician perspective, but also from being a patient. I mean, I guess start with, from a physician perspective, when you knew things were coming down the pike, what were you preparing to do? And then how did your diagnosis kind of come up?
Yeah, I think some of the, irony of it was, I had actually just, I had seen Scott the week before here in Boston, and Scott had gotten the email while we were at dinner saying, oh, this is going to be my last trip. MD Anderson is canceling trips, and at MGH, we still hadn't gotten there. All the big meetings were being canceled, but weren't quite there yet, and we were still early. We didn't have testing yet. The following week in clinic, I had a pretty routine clinic week, and Wednesday morning I started developing a little bit of a cough and a little bit of chest tightness. I called occupational health, and again, we were so early. I taught fellows that morning. I attended our tumor board, which we were still doing in person with pathologist and interventional radiology and surgery and radonc. So around 50 plus, some people in a room. Did clinic, saw 20 plus some, I think 23, 24 patients on Wednesday, and new patients on Thursday as well. Did research meetings and things. And I think the irony of it was, I called occupational health, and at that time there was no fevers or anything else, just a cough, but I was nervous, and they cleared me to work, so I worked. I actually did wear a mask that day. Just, I informed my patients, I feel okay, but, I'm just going to be careful for all of us, but exposed a lot of people. And went about my day Wednesday, Thursday, and then Friday just started not feeling, just the cough was getting a lot worse. And, I went for a run Thursday morning, and then Friday was having a little bit of trouble getting up a flight of stairs without feeling pretty winded. And I was like, this isn't right. And so I called, and at that point, just on that Friday and Saturday, MGH had rolled out their internal testing too. So was run and was actually the first healthcare provider at the hospital that ended up being confirmed positive. And you know what was hard, I think, as an oncologist too, was and my parents happened to be with us for some of my own parents' medical issues at that time too. We had planned on sending them the week after driving back to Indiana, knowing that my husband was going to be starting in the ICU. So we thought that their exposure was going to come from him, and sort of the irony of it coming from me. And so I had to sort of process a lot of my own guilt around a lot of that exposure for those patients. You know, having to early on in the pandemic, having to have conversations with nearly 30 some patients that I exposed to, and talk about that and what, you know, allay their fears as well as I'm quarantined, you know, myself from my family. There was just a lot sort of happening, I think, at that time. So, you know, fortunately, you know, no one that I at least directly know of, you know, contact-wise, ended up getting sick. But I think that the biggest thing is that there's so much we don't know, you know, and everyone's, you know, we have up to 30% potentially asymptomatic carriers in some of the testing that's happening in Boston, and you know, some of the pregnancy data out of New York when they were testing OB units, kind of similar rates. I actually did do antibody testing myself too with some of the in-house work that's being done, and very perplexing to a lot of us. Despite 2 antibody testing, my antibody testing was negative, right? So, and then they looked, we did a confirmatory, I had a couple of positive tests because they had to send it out to the state lab too initially. So the PCR, PCR is pretty sensitive too. So it was definitely a diagnosis, but you know, antibody response wasn't there. And is that an issue with the assay? Is that an issue with the right antigen? And was there, you know, looking at IgM and IgG, was there a local IgA response? So all sort of technical things, but I think to me, I think what the whole experience sort of spoke to was just that there's so much we don't know, and the variability is vast, and the uncertainty of it all is, it's going to take a long time for us to really understand this. And I think it behooves us as a community to thoughtfully answer questions, and, you know, provide and generate evidence, and, you know, actively study all these questions, because from testing to immunity and prevention, we don't know. So, and manifestations are so varied.
Yeah, well, thank you for sharing your experience. We're so happy that, you know, you went through it, and I mean, you look great, you sound great. It's, you know, people focus so much on, especially because it's in your face everywhere, on the tickers, on the news stations, you know, like all the death rates. And it's so nice to see evidence that people are getting through this. And, you know, when you think of the number of people that are dying, you also have to kind of contrast that with the number of people that are diagnosed and living. So I think it's, especially in the cancer community, it's important for us not to let the anxiety of what might happen at the worst take over that, you know, there are people that are getting this and getting through it. So thank you so much for sharing your experience. I think that that's very helpful. And we'll also post, Doc had written an article about her experience, and we'll be posting that and sending it out in the post program emails as well. So thank you again for that. Dr. Bada, I'd like to talk with you about what types of things have changed in your day-to-day practice of medicine, both maybe for the good and for the challenging.
Absolutely. The day-to-day has changed completely. Whereas we would be going into clinic and to the lab, everything has been turned on its head. Now going into the clinic alone, the cancer center requires screening, both patient entrances as well as provider entrances, screening of patients for both temperature and symptoms. Everyone's wearing a mask universally. California has been very lucky at this point not to hit a major surge, but we're all ready. We've been, again, trained as internal medicine doctors. So at the end of the day, if necessary, we'll go in just as Dr. Kopetz and Dr. Parikh have. And at the end of the day, our patients are asking the same questions we are. You know, how are we going to keep things up and running, keep the chemotherapies, targeted therapies, immunotherapies, and clinical trials running? And I'll say that our institute, we're lucky to have a lot of resources, as are a lot of academic institutes, in keeping the normal as can be. And our patients do feel the risk is down, that they're able to get their treatments. It's unfortunate that those treatments take place alone, without family members around. But a lot of our patients are actually looking forward to coming in and socializing with our nursing staff or physicians. So, you know, like I said, it's a new normal, but, you know, at the same time, it's still the same algorithm and keeping it running. And our patients, our family members, our institute, our colleagues, you know, at a time of crisis, everyone bonds together. It really is a community getting patients through this, and you really do see that at times like this.
Yes, yes, thank you. Dr. Kopetz, I know that MD Anderson has been really strong in the area of being able to provide patients with telemedical visits. You know, while the community and maybe even some smaller academic centers have struggled through, you know, those platforms, and it's been so great that the government services have relaxed some of the HIPAA rules around, you know, even using your FaceTime to interact. But talk to me from a physician perspective of what does it feel like from your seat to do a telemedical visit? I mean, I think that that's something that patients probably would be interested in hearing. What's your perspective of that visit?
Yeah, I mean, I think to reflect back to Steve's comment earlier about trying to find, you know, silver linings in the midst of all of this, I think it's been great to really kind of accelerate the kind of telemedicine efforts, because I think this is an opportunity where we can provide, you know, the right care to patients in a way that's more convenient to them once we get back to normal as well. But, you know, during this time, it's something that we've utilized very heavily. You know, we're still seeing patients in the clinic when we need to, you know, when there's symptoms or complications or things that are a little more complex to discuss. So it's still very much a mix of face-to-face, but trying to for a lot of our routine toxicity checks, really have moved more towards a telemedicine effort. And I think that's been viewed very positively by the patients. You know, a lot of times they're still coming in, obviously, to get the blood work and get the treatment, but if there's, you know, one less healthcare encounter that we can minimize for them, then that's a positive. And I think that's been been well received. I think it's still not quite the same as a face-to-face, and so I think you know, there's still a lot of the you know, a lot of the body language that doesn't come across, the nonverbal communications. You know, I find it harder to project empathy, perhaps, and to kind of really share the experience with the patient, especially if they're, you know, sharing tough times they're going through or symptoms. There is still a little bit of there's a disconnect there. So it's not ideal for when things are not going well. And I think what we're trying to do is find that right balance, right? When is it that we need to have that still have that face-to-face connection and have those conversations together in a safe way. And so it's also very individual. You know, some patients, you know, love telemedicine and they are excited and very positive about it. I think for others, it's not a good approach and not a good medium for them. So it's still one of the options that we give patients, but it's still something that is interleaved among kind of the face-to-face conversations as well.
Yeah, I've heard a lot from both physicians and provider and patients that, you know, for the routine things, oh, your blood looks great, thanks, see you in a couple months, that it's easy. But for some of the more difficult conversations of, you know, are we going to pivot to do something else, or we found something that we, you know, need to kind of explore more, that it's hard because there's such an energy between a physician and a patient, and you almost get to learn to read those energies. You know, like, are you really worried about this? Or if you can sense that I, as a patient, I'm really worried, you kind of pick up and say, wait, I don't want you to get worried. I want you to know that this is our standard. So I think a little bit of that gets lost with the screen. And I know that, you know, for a lot of patients and physicians, that's been hard on both sides, that, you know, you do want to reach out and say, don't worry, in a way that the other side believes it, you know? So I'm grateful to hear your perspective on telemedicine and how it's...
On a lighter note, what I joke with my patients, the thing I miss the most is being able to see the spouse over their shoulder that gets, yeah, he's doing fine, or, oh, no, that's not right. So yes, I almost want to pivot the camera to your spouse for a minute. I need to, you know, confirm what you're saying, but
yeah.
No,
and in that same vein, I was talking to a doctor, a girlfriend of mine, and she was saying, you know, I did this FaceTime visit, and there I am, and I've been seeing this patient who drives up, probably about an hour from where we live, drives up to see me in clinic, and she says, so we have our set time, and I call her, and literally her whole family is like in the background, and then there are they have on other phone screens, mom who's in New York, and this, and it's like this full room of family members for the first time getting to meet and thank the doctor. So, I mean, there are, you know, again, the silver linings of being able to have everyone in the room, because you wouldn't be able to do that in a normal clinic visit. Dr. Parikh, I'd like to ask you, are you seeing patients, are they coming in and sharing worry and anxiety with you, or are they kind of trying to mask that so that they just kind of put up a good front? And then how are you managing those conversations?
Yeah, I think, I think anxiety is expected and normal, and I would say essentially universal right now from everyone. I don't think I've had a single kind of patient interaction that hasn't had some level of anxiety, whether it's a decision to, move back a surveillance scan. And I think, one thing I think it's important just to mention is the immense effort of trying to maintain optimal and the best care for patients, particularly oncology patients during these times. We are having extensive multidisciplinary meetings with our surgical colleagues and our radiation oncology colleagues every week, on the order of 4 to 6 hours of reviewing case by case upcoming patients that have surgery planned, chemo decisions, and we're putting a lot of thought into that too. And so because it's important to still provide, the best cancer care we can, but as providers and also as patients, we are very much aware of what is happening, and that includes what our hospital is capable of taking care of during these times where we have a nearly 1,000-bed hospital that has, nearly 200 patients on ventilators from COVID and nearly 400 patients, COVID inpatients. And so we're trying to, and people are nervous about coming to Boston downtown too, where in these settings where they know patients are. And so we're being really, I think, creative and adaptable and working in an unprecedented team effort that I haven't seen before, and to try to make individual decisions and use our best judgment in making decisions for patients, from both the curative patients, palliative patients, follow-up patients. And I think every conversation has to be tailored to that individual patient and individual situation, and try to assure them that there is a team of people thinking about their interest and, you know, why we're making the decisions we're making. It's hard telling some patients, like, we're not going to be able to get your surgery done, you know, as planned. But here's why. We're seeing some data that COVID positive cancer patients that undergo a surgery, I know, have up to a 30% mortality too. And so these aren't decisions to be taken lightly. We're trying to be creative about lab draws and getting lab draws locally, and, you know, again, virtuals, and protecting the patients when they're in the clinics and having to come and get treatment or get admitted. So I think anxiety is universal and expected, and that's okay. And I think we just have to work together to recognize that there's a lot of unknowns from their end, but also our end too. And we're just doing the best we can to take the best care we can of people.
Yes, thank you, thank you. And before I move on to Dr. Botta, Dr. Parikh, are you currently seeing patients? Are you cleared and back to seeing patients?
Yeah. I had two. I had another positive test and then had to get cleared again. So I've now had a couple of negative tests, and so I went back a couple weeks ago outpatient, and then like I mentioned, I went this week. I covered a non-oncology COVID floor.
Got it. Thank you. Dr. Botta, as you're, you know, thinking about what Dr. Parikh said in terms of making considerations for COVID in treatment planning. So, you know, you once had an algorithm that was either guideline directed or you're involved in clinical trials, so it's protocol directed. In this new space of having to incorporate COVID-19 in all of those decisions, do you find yourself heavily on, and then are you communicating that to patients where you're saying, look, in the old days, this is what we would have done, but because of Z, this is something that I'd like to communicate and maybe make a shared decision? Are you finding yourself in that headspace when you're practicing?
Oh, absolutely. You know, I think shared decision making is a part of every oncologist's program at the beginning. A lot of these patients are coming to us now very well informed. They're at home 24 hours a day, 7 days a week, on the message boards, watching television, and they have an idea about where they want their treatment to go. You know, some of our patients are coming to us asking for specific regimens, saying, hey, I read this paper from Dr. Kopetz who says oral medications are the way to go for this disease. And we're saying, absolutely, we have that leeway now to be able to do these things. Whereas before it would say you're coming in for adjuvant therapy, you're going to get FOLFOX because this is standard of care. We're now opening it up to saying, all right, well, let's go to maybe a Capox regimen, or you don't want to get a port, let's go to Xeluri with Xelota with irinotecan. So there's all these different ways in which we have had these standards in place that are now kind of shook. The idea is that our patients are being educated about this up front, and we don't know a lot of times what the outcomes will be with one treatment or another, but we have to use the tools available to us to get the best outcomes. And then there are some patients as well who are saying, you know, do I want to get therapy? Do I want to stop all therapy because I have other comorbidities? I'm a high-risk patient. I think it's best that I just hold my therapy for now and go on to active surveillance. So, you know, I think with these decisions with our patients, it's always an engagement and a discussion. Our patients are very sophisticated, and we will always be able to come up with a treatment paradigm for them, especially in the day of next generation sequencing and targeted therapy. There's a lot of options now that are not only IV based.
Yeah, thank you for that. And Dr. Kopetz, along that same thought, when patients are saying to you, I'm scared, I'm in the middle of something, or I'm scared because I'm overweight and I have asthma, or I'm overweight and I have a heart condition, how are you counseling through the risk benefit?
Yeah, no, it's a great question, and I think I think the first thing to do is to as Aparna mentioned earlier, and I see Paul Billings had a similar question online, is just acknowledging that we don't have as much information as we'd like, right? And I think, and that's kind of the first start of that conversation, is just acknowledging that, like you said, some patients that have some, certain other comorbidities besides cancer may have a higher risk. And so, so that's where that shared decision making that Dr. Botta mentioned really comes in, is thinking about acknowledging that any treatment that we give has some degree of benefit, and that in a normal non-COVID world, this treatment is recommended because that benefit outweighs that risk. And sometimes that's a dramatic outweighing the risk, and sometimes it's a very modest incremental benefit that outweighs the risk. And so part of it is just really putting in some degree of that uncertainty and some degree of that potential risk that comes from being under active therapy or more intense active therapy in the setting of potential for a COVID infection. And so, so that the communication that we have with patients really has to kind of reflect the fact that there are some treatments that we'd say that even in the setting of potential risk, we still do it, right? That this is absolutely something we need to do. You know, you're newly diagnosed with metastatic disease, absolutely, we've got to get you started on treatment, right? But then there's others, you are 5 months into an adjuvant, regimen. The incremental benefit of that additional month of adjuvant therapy that, that is borderline at best, certainly would come with a risk that in many people's minds, including mine, would outweigh the potential benefit that could be there. And so in that setting, you'd say, okay, in this new environment, we're going to, change our treatment plans. And I think the key thing for us to communicate as doctors when we're doing this is that it's not that we're giving, less optimal care for the cancer. It's that we're looking at the total patient and looking not just at the cancer, but at other risks as well. And so we're really giving optimal care for the totality of the patient. And that's I think, something that we as providers really have to continue to communicate, because it is anxiety provoking. And I completely understand when you said, but 5 months ago, you said I needed 6 months of adjuvant therapy. Why are you all of a sudden saying 5 months is enough? But I want to do everything that I can to prevent the cancer from coming back. And so it's that conversation to say it's the totality of the picture, the totality of the risk. And our job is not to optimize your cancer outcomes. Our job is to optimize your outcomes, and really having to work with that framework.
I love that. I think that probably is such a big takeaway from a town hall like this, that when you are worried about changes in your doctor's decisions for your therapy, it's because the doctor now is not just considering how do we take care of this cancer. The doctor is saying, how do we take care of you with cancer amidst a pandemic? And I think that is such a powerful takeaway, because then it resets the patient's mind so that they know that you're not only taking into consideration the things that are right in front of you, but the things that are not, when their husband is going to a grocery store or they don't have gloves or whatever. The real things that are happening in their life, their daughter works at a grocery store. Like, these things I think are very important for patients to know, that you're looking at a bigger picture. So thank you for that. Dr. Parikh, do you find that in this time, oncology is such a multidisciplinary, interdisciplinary, peer-to-peer practice, because based on so many different factors and nuances, what you do for one patient, even though national guidelines may say this, population health may say this, you're dealing with an individual right in front of you. So do you find that in this new normal, that you still have the same level of reliance on those peer-to-peer conversations, and maybe even tapping into some of the states who are further along the line, who have had experience with patients with cancer, with COVID, Are you finding that you are relying a lot more on those peer-to-peer interactions, and then how amidst crazy schedules?
I think as I was trying to allude to a bit earlier, what I've been so impressed with is, in fact, I feel like our multidisciplinary care experience and model has in many ways been enhanced because we're all trying to make these really tough decisions together. One of the things that we've always done for new patients at MGH is we try to see them together with surgery and onc, and we haven't stopped that, and we're doing it virtually, but we're still having multi-clinics and running those. You know, we will meet obviously people before they're actually starting active treatment. Just that face-to-face is so important, just to get a sense of whether the treatment plan that you've outlined virtually too really does make sense for that patient once they're sitting in front of you, and that visual that even a Zoom can't replace in terms of how someone is really doing. But we're maintaining our multidisciplinary visits, multidisciplinary cares, and have actually added on more venues for these discussions for patients that maybe had a plan already, then when that plan may have to veer for whatever reason related to the pandemic. I've been really impressed with my colleagues and the team in terms of how thoughtful and the promotion of and the value that's been placed on having these peer-to-peer discussions, because I think it helps us as providers, but most importantly, it helps the patients too, because we're all talking about it together.
Yeah, thank you for that. And then Dr. Bada, I'm gonna ask this question to you to close out the medical expert session, although we've got a lot of Q&A that during the next session, if any of you would like to jump on and answer specifically, that would be great. Dr. Botta, considering that we started this town hall listening to patient advocates and how they're reaching out, how do you find, or how do you feel, or what are some ways that the medical community could partner up with patient advocacy groups in the spread of information and resources?
Yeah, absolutely. I think that it's the spread of information, is number one, and accurate information that the patients can know comes from a source that they can trust, that has a particular knowledge base. I think a lot of times in this pandemic, there's a lot of misinformation, and that gets people even more worried or more anxious. And having a dedicated resource where you feel that you can trust the information and it's coming from a clinically validated or evidence-based medicine source is highly necessary. Additionally, I think that a lot of what people are doing right now in general is helping. These lunches that are pouring into the clinics and into the hospitals from donations of funds have been immensely helpful for the staff that have been working 12, 14 hours, 16 hours and more. Additionally, I think that having a source for patients to vent either anxiety or frustrations, but have that supported and not pushed forward to heightened anxiety is very necessary. I believe what they've done in the past can only be more important nowadays, and there's nothing new or nothing that is going to be novel in all of this. It's going to be that we need to be patient, we need to be human, we need to interact with one another, engage with one another, help diffuse a lot of the anxiety and support one another. And I think you see that daily with people clapping, with physicians going into the hospitals and online, and it's just support right now. And as long as that continues to move forward, I think we'll make it through this well.
Yes, yes. Well, as I said, we've got a lot of Q&A, so while we transition to our next session, an interview with industry and how they're helping manage through COVID-19, I again want to say thank you, not just for being part of the virtual town hall so far, but also for what you're doing on the front lines. I mean, initially you just sit there and say doctors on the front lines, you start thinking about Doctors Without Borders or things like that. But the reality is you guys are on the front lines. I mean, you're working in an incredibly risky environment without all of the tools and resources that you need. And so it's incredible what you're doing. I thank you so much. All of us thank you so much. And you know, as we get into the Q&A, we are going to ask what we can do to help support physicians and other members of your team during this time. So I'm going to ask Dalen and Raina to transition out Dr. Parikh, Dr. Bada, and Dr. Kopetz, and then bring up Dr. Alishan, who will be joining us from Natera to talk about Signatera and some of the things that industry, and when we say industry, these are companies that provide goods and services for patients and physicians and other members of the healthcare team around cancer. So Dr. Alishan, so nice to have you here, and I'm so grateful that you accepted the invitation to come on and talk about ways that Natera is helping fill in some of the gaps in medical practice. I guess I'd like to start with what or who is Natera? If you can just give us a little bit of background on the organization.
Great, Sarah. First of all, before I get to that question, I just wanted to thank all the panelists and attendees who are able to join us today. You know, I think it's just so eye-opening just to hear how COVID has touched not only our patients, but also our treating physicians and their families. Currently, I'm taking this call from New York, and my wife is an ER physician here on the front lines, actually sleeping before her next shift next door. So it's just been amazing to see how this pandemic has brought the broader community together, especially physicians, patients, as well as industry, really to work towards a common goal. So to Sarah's question, you know, who is Natera? Well, Natera really is a group of clinicians, scientists, researchers, as well as our talented laboratory staff, really kind of all around the world, who really come together towards a common goal, and that's improving how genetic diseases are managed. So we focus as a company on liquid biopsy testing across 3 verticals. Those include women's health, transplant, as well as oncology. And we develop and commercialize non-invasive assays to detect circulating DNA. For oncology, that's detection of circulating tumor DNA. We have a laboratory that's in San Carlos, California, and then a second laboratory in Austin, Texas, where we conduct our testing.
Perfect. And describe to me, what is Signatera?
Yeah, definitely. So Signatera is our assay that we've developed for the oncology market, and it's really the first personalized tumor-informed assay for detecting circulating tumor DNA to identify both minimal residual disease, also known as molecular residual disease, in patients with early stage tumors that have undergone definitive therapy. This is really a test to identify which patients may have residual tumor left after their surgery, for example, who may be at high risk for recurrence. And then on the flip side, for patients who don't have evidence of circulating tumor DNA, this test can be a very helpful tool to really identify the patients at a higher likelihood of being potentially cured of their disease. Furthermore, in the surveillance setting, really Signatera has a lot of utility to identify patients who may have disease that may be molecularly recurring, to really try to identify patients who may be at high risk of recurrence. And again, this is to be used in conjunction with standard surveillance methods like imaging or CEA.
So when you say tumor-informed, what does that mean, tumor-informed?
Yeah, that's a great question. So I think the liquid biopsy testing market, you know, it's very diverse, and there's really various tools for different needs. I think many on this call may be familiar with tests that are kind of these liquid biopsy tests to identify actionable mutations. Usually this is for patients with advanced or metastatic disease to, for example, identify a BRAF mutation that may be tied to a particular therapy. We really focus on using liquid biopsy technologies for a slightly different purpose. And again, that's identifying extremely low levels of tumor DNA in the blood that may be coming from tumor that may not be even visible with standard methods, including imaging or other blood tests like CEA. And the tumor-informed component means that we actually really use the information from that patient's tumor to really look for the mutations that we've previously identified and be able to create what we call a bespoke or personalized test that's really tailored for that patient's particular tumor, really allowing us to be able to look much further down into the plasma to really identify these needles in a haystack, these rare molecules of tumor DNA that previously were just too low and kind of below the level of detection of traditional liquid biopsy tests.
So this test actually takes, if I'm the patient, this test actually takes a piece of my tumor, takes a picture of it, develops some type of personalized signature, and then matches that with my blood. Is there a blood component to it?
Yeah, well, that's a great question. So the way the test works, this is ordered by your oncologist or other healthcare professional. And the test basically requires a prior cancer diagnosis. So this is a test for folks with a diagnosis of cancer. The test uses the tumor tissue from either the initial biopsy or from the resection to, as Sarah said, really take a snapshot of the mutations in that tumor to then design a custom test to look for those mutations in the plasma. So for every test after the assay is designed, we take a blood sample. So that's usually just 1 to 2 tubes of blood, which are used then to examine the plasma in that blood to see if those tumor molecules can be detected. So again, to really identify those needles in a very, very deeply into that plasma.
Wow, I love that. I love that there, it really does make a personalized signature for me as a patient that can be tracked. So Dr. Allison, we've talked with now patient advocates, medical experts on the front lines treating GI cancers. There's been so much conversation about what are essential. Going back to what Dr. Kopetz was talking about, we're not only now treating the patient with cancer, but we're treating the patient with cancer during the time of COVID. What do you have to say about surveillance and its importance during this time?
Yeah, that's a great question. So kind of during this new normal, with the pandemic that's occurring, we're definitely hearing from a lot of our physicians as well as patients that standard surveillance visits are either being delayed or canceled. And that's really to both prevent patients from possibly coming into high-risk environments where they may contract COVID-19, but also because a lot of the facilities are being used to help the fight. A lot of the CT scans are currently being diverted to image patients who may be suffering from COVID. And really because of that, we're seeing that surveillance, which is really a standard part of patients' care and follow-up, is being delayed. And obviously that can create a lot of anxiety and a lot of worry. And Signatera is a tool that can be used in conjunction with other tools that are usually used for surveillance purposes to really kind of allow for a non-invasive method to detect if the cancer is still in remission or maybe possibly recurring. So because this is a blood test, there's no need to come in for imaging studies, and can also now be done in the privacy of a patient's home. So there's now mobile phlebotomy options where somebody can actually show up to your home, draw a blood sample, and allow for testing to see if any tumor traces can be identified, which again could be a sign that the cancer may be recurring.
That's fantastic. It's so innovative that the company has looked at the bigger picture of the way doctors are treating and the way doctors are triaging and saying, we still think this is such an important tool to surveil patients in a specific setting. And this is our fix. We're going to take it to the patient. We're going to minimize their contact and their exposure. So I think that that's incredible. So along that same vein, and before we actually have a patient who has experienced this, and we'll be asking her a few questions surrounding her disease and surrounding the experience. But talk a little bit about Natera and this expanded access program and how exactly it works. If I'm a patient watching this town hall right now, and I'm in the surveillance setting and I've been sent an email or given a call saying, hey, we're going to wait a couple months before we bring you back in, what exactly is this process and how can I communicate it with my doctor?
Yeah. So at Natera, again, we are really hoping to partner with the broader oncology community as well as the broader patient community to really offer this type of testing during these difficult times. And really to accomplish that, we've launched what we were calling the GI Expanded Access Program. This is a program that actually allows testing not just for colorectal cancer patients, but for the broader GI or gastrointestinal cancer patient community. And this is for testing both in the neoadjuvant setting, so this is to allow for treatment response monitoring, so understanding if the tumor is responding to therapy even before surgery, since we're seeing a lot of patient surgeries now being delayed. Also, this program covers the post-surgical or the adjuvant setting, and this is the period of time where that critical decision needs to be made about if a patient should be started on additional chemotherapy. And then also in the surveillance setting, where patients are being surveilled to see if their cancer is still in remission or is at risk for coming back. So again, GI Expanded Access Program covers all of these indications. And really, the goal of it is to provide easily accessible testing for both physicians as well as patients. So really kind of the steps to be considered for the program would be to first of all, have a discussion with your oncologist. Signatera is a complex diagnostic and really should be only ordered by your oncologist, who will also be able to then interpret these results. So after that discussion, there's information on our website about the GI Expanded Access Program that can be provided to the oncologist. And the test can be ordered electronically. So you don't need to actually come into the physician's office. The test can be ordered electronically by your doctor. And depending on what's easiest, you can either then have the blood drawn at your physician's office, at a local lab, or actually utilize a service we call mobile phlebotomy, where somebody can actually come to your house and draw your blood safely in the comfort of your own house for this type of testing.
Wow. I mean, I really applaud Natera for everything you're doing to help support the community and the patient community, because I do think that, people who are living, under the risk factors still have very real questions. And while you do have to triage, people coming in and risking their exposure, I think it's phenomenal that the company has decided to expand access with other types of GI malignancies, as well as provide the service to have people go out to patients' houses. So I think that it really needs to be applauded that the company has thought through this program. I want to thank you so much for being part of this and for just giving us a glimpse. Natera is one of many companies that are looking for ways to impact patient care in this new normal. So I want to thank you for featuring how you're doing it with Signatera. And in our post program communications, we'll be sharing information from Natera about how to access this program. So thank you again, Dr. Alishan, for your time. And we're going to go right into the patient testimonial. I think this is really the pinnacle of the whole conversation that we've been having. We started with patient advocacy, why it's important, what resources are available. We went into medical expertise of, how physicians are working in this new environment, and then how industry is, partnering with other stakeholders to deliver care. I think it's really powerful to have Angela on with us and sharing your story and a little bit about your journey with us, because I do think that textual is everything that we've been talking about it, and it humanizes it for us. So thank you for sharing your story with us. And I'd like to, just ask you to, start from where matters the most, having participated in this town hall, and what you'd like to tell patients about living with a diagnosis or living in survivorship at this time.
Well, thank you, Sarah. Again, my name is Angela Gangler. I've been living with stage 4 colon cancer since 2015 with active disease. And as Steve kind of mentioned, a lot of long-term cancer patients are kind of used to the uncertainty of living in the land of sort of long-term treatment. But COVID has definitely added another layer. And I quickly found that out. I had been traveling early March internationally, not understanding that a pandemic was completely going to explode soon. So I had to come back early, and I was due for scans March 20th. And I got a call. I spoke to my oncologist right away, and he said, well, you need to quarantine for 2 weeks. I said, yes, we're doing that. And then they asked me to delay my scans till May 1st. And that would have been pushing my surveillance scans past another month, and I wasn't really comfortable doing that. But right away he said, well, let's order mobile Signatera. So you can have your scan or your liquid biopsy drawn from home. And I've had a Signatera draw before, and it's been very helpful as a monitoring tool for my minimal residual disease. And so he got that set up right away, and had the draw from home. It was very easy, did it outside. And I got those results very quickly, actually, before my CT scan was scheduled. So I had an idea about whether or not I needed to really push up that CT scan, or I felt comfortable delaying it another month. So, yeah.
Yeah, and tell me about, when all of this, when COVID kind of first started coming down, news stories, China, then other parts in Europe, then a couple of cases in California, and then it felt like all of a sudden it was on us. Like all of a sudden everything was closed and, to be sheltered and all of the seriousness. As a patient, how were you processing that?
Well, my first thought, I was in Costa Rica, and when we were in Costa Rica, there were no cases in Costa Rica, and there were no cases in my home state. So my family and I were really watching it unfold as we're, in a foreign country, thinking, okay, when do we come home? And I knew that I was due for a scan and possibly a treatment change right when I came back. And so we coordinated leaving early, while I was also emailing my oncologist saying, okay, I've been traveling, how are we going to adjust scan times? Or quarantining, how are things going at your facility? Because I get my scans out of state. And so I didn't know how things were looking in his home state, nor did I really know how things were looking where I lived either. So it was kind of stressful, and we were prepared to just kind of roll with it as information came in.
Yeah. So, going back to what the doctors and even a little bit of the advocates were saying earlier, so much of cancer care is shared decision making. And it sounds like from the get-go, you and your doctor were in constant communication about what impact will this have on your care, on your disease, on your monitoring, et cetera. So when you, knowing that you had Signatera already in the clinic, when you heard that they had this mobile phlebotomy option, was it easy to say, yes, sign me up for that? Or did you have concerns about who's coming to my home? Will they be protected, et cetera?
Yeah, I was definitely a little bit hesitant because I didn't know who would be coming to my house and whose houses they had been to previously. So the company was good. They called me just as sort of like a pre-interview to make sure that they were sending the right test, just clarifying what tests they were drawing. Yeah. And that gave me an opportunity to ask them if they had gloves and masks. And, I have a port, so I could ask about, can you draw from my port? I'm kind of a hard stick in my arm, does your phlebotomist have experience with that? So that really helped sort of quell some of the fears. I also came armed with my own PPE that I already had. So we had a very nice blood draw on my front porch, maybe to the neighbor's enjoyment.
Very good. I'm so, you know, I love hearing these stories of how kind of everything reaches back down to the patient. And I think it's so courageous for people who are in your position to share your story and to kind of encourage each other people that are also, you know, in like positions, to say, people still see us, we still, you know, the show must go on, and that, you know, at the end of the day, the care team will get together to make sure that my care is kind of optimized during this very uncertain time. So I really do appreciate, I'd like you to stay on. I'd like you also, I'd like Dalen to invite everybody back on. We've got about 15 more minutes of the town hall where we're going to be taking questions live on Facebook, as well as questions live in the chat, and going over some of the questions too that have been opened for the benefit of people who haven't been following along in the Q&A. So before we get going with that, again, I just want to say thank you so much to everyone for doing this. I know it's time out of your schedule on a Saturday, but I can't tell you how much it means to people, because they don't only have the option of watching it live, they have the option of kind of, when everybody's tucked in and in bed, going through and seeing all the resources that are provided by advocacy groups, the way their medical care teams are banding together to ensure that their care is not just continued, but continued with a directed focus on making sure that they're not okay. They're okay with their disease, but they're okay just kind of living as a citizen during this pandemic. And then seeing how industry is stepping in, I think it's incredible, because we all have to be so much more creative at this time. So I want to thank everybody so much for your time on this town hall. We've had some questions. I'm going to go back through it. So a few of the questions have been, are there ways we can share information about resources available? So for the advocacy teams, I'd like to just ask Andrea, Sharon, and Steve, if you could just, in one sentence, if you were getting off an elevator quickly with someone who said, how can I reach you? What do you have to say about ways that patients can access your resources?
I'm happy to start. Yeah, so I would say the first thing is obviously our website, ccalliance.org, and then we also have a helpline. So for patients and caregivers who are listening who may have individualized questions or really want that navigated support, our helpline is the best resource for you.
Okay, wonderful. Steve, Colontown?
Yeah, if you're a patient or a caregiver, colontown.org/join is our registration portal that gets you directly into contact with our onboarding team. And the good thing about that is that, not only are we interested in kind of finding out, your situation, but we can help steer you into those communities that are the best fit for your particular situation.
Sure, thank you so much. And then Sharon, Fight Colorectal Cancer?
Sure, so I would recommend visiting our website and signing up for our patient e-guide, which is a regular newsletter where we'll have updates around COVID-19. We also have a page dedicated to that on our website that we update regularly. And then also we have a support line in partnership with Cancer Support Community that are open extended hours Monday through Friday, and then Saturday and Sunday as well. And that information can be found on our website.
Okay, and just give me your website one more time so I can type it in the chat.
Sure, yeah, fightcrc.org.
Fightcrc.org. You guys were keeping it simple. Okay, next question we have. A lot of compliments to all of us, so I'm just going through. Okay, Oh, this is a great question, maybe for the whole panel. How do you recommend people, just in general, stay connected when we feel so disconnected? And maybe I'll start with Dr. Parikh first.
Yeah, I think, I think everyone has to, find their ways that makes them feel connected. It's sort of, we were sort of joking that even on the quarantine, we felt like our social lives with the Zoom calendars was bustling, and it was almost more busy to manage with it, with how much, between family and friends and, various stages of life and groups of people and work colleagues all getting together. So there is a lot of camaraderie and a lot of recognition that this is a very isolating time for everyone, and find your people, and who are those people that provide you strength and support, and bring a smile to your days in these times. So I don't have any sage advice, but I think we're all
I think that's sage advice. Angela, how about you, from a patient perspective? How do you stay connected when we feel so disconnected physically? Oh, you're on mute. Sorry, let me try to unmute you. Zoom challenges.
Yeah, exactly. Well, my care team is kind enough to give me their cell phone numbers and all those crazy things. So we stay very connected. And that helps when you're trying to make decisions in real time after office hours and that kind of thing. That's really, really helps. But, I try to stay connected with my family, and that helps, just that the human component, and then I can be calmer and make those tough decisions with my care team.
Yes.
I sort of also, I'm a hugger in clinic for sure, and so I'm always sort of signing off these virtual calls like, I'm giving you a hug even though I'm not, and so it's hard to not have that touch, because I find myself like putting my hand on people's hands and hugging a lot, and so that I think just letting them know, even if it's out loud, that you're with them and you're here, and you wish you could give them that in-person hug, but you're very much with people through these times. So
yes, thank you for that. I think that resonates with all of us in a different way, like similarly, but in a different way. We miss and we crave that physical connection outside of the people who we're probably, for the people we're living with, we want to push them out, but the people who we haven't had the connection with, we crave the time where we can all kind of connect again physically. Okay, Dr. Botta and Dr. Kopetz, do you think that there's going to be permanent changes in cancer care going forward as a result of this? Dr. Botta, I'll start with you.
I do. I think we're already seeing it. It's the implementation and loosening of restrictions for telemedicine. And I think it has a place in our care of our patients. You're absolutely right. If you have a follow-up visit and you're doing well and your labs are done at a remote draw and your CT's been completed and we can show you online, you don't need to come into the clinic, and we can do a telemedicine visit. And I think that'll stay in place. The patients who are coming in to get treatment, we'll see you on those treatment days. And I think it's important to have that human contact, just as Dr. Kopetz and Dr. Parikh said. You have to be able to be there, see the body language. Whether or not we'll loosen the visitor restriction earlier or later, I think eventually it'll come around that you'll be able to come in with family members. But at the end of the day, I think some of these things were kind of forced into place, but are necessary. We have the hardware, we have the telecommunications power. We're not going through a pandemic where we're all isolated. We can connect on Zoom meetings. So I think that using this technology nowadays has been very empowering for a lot of people.
Yes. And Dr. Kopetz, things that you think will be permanent as a result of this?
No, I second that. So I think, hopefully, telemedicine, as I was alluding to before, really kind of making sure that we're, as providers, really thinking carefully about the risks and benefits of anything we're doing. So it's not just, I do this because the guidelines say X and I don't do Y, but it's really what are the the risks and benefits and the magnitude of difference between those in those different scenarios. So I think that there will be some change to how we're thinking, and part of it is, I think, the recognition that it may not be, a snap of the fingers and we're back to normal in, 2 months, 3 months, that there's going to be probably for the foreseeable future some level of risk that's out there. And so I think this is something, even though it may be much less than what we're dealing with, right now in the middle of April, I think there's going to be a subtle rethinking of a lot of these things that we're talking about, I think, over the next year, at least as well. And I'll echo a point that Steve made really early on, which is I certainly hope that this can drive some increased flexibility for clinical trials. It's absolutely needed, and I think we have seen a lot of flexibility during this time in terms of accommodations for patients that are already on trial, and so I'm hopeful that some of that will be able to kind of positively change the landscape of clinical trials in the future.
Mm-hmm.
Right. I also think, to Scott's point too, I think we'll also get to learn a lot from these times, and I think we're trying to capture how we are caring for these patients, and does pushing out neoadjuvant therapy, is that actually helpful, or is it not, or giving neoadjuvant in cases where otherwise you may not, or to Scott's point, these marginal benefits of adjuvant therapy towards the end, what are outcomes looking like? And I think we're trying to be thoughtful as a community too of how we can actually also use this as an opportunity to learn and maybe inform patient care and inform future trials, and perhaps even improve care in a way going forward as we're starting to measure how we are caring for patients.
Yeah. Okay, well, I'm going to end with 2 light questions. Thank you again so much for everybody being here, and we had almost over 200 people participating in this town hall live, so I can't wait to see the impact too of it as it goes on. Different advocacy, social media posts, and our posts for education, etc., patients sharing with each other, because I think we went over a lot of really powerful resources. So I'll end with these 2 light questions. First question, going around the room, starting with Angela. What is the first thing you'll do when we're all allowed at least to step outside our front door?
Oh my gosh, I'll go hug all my neighbors. Love my neighbors.
Very good. Andrea?
Maybe I shouldn't be saying this out loud, but I'm pretty desperate for some time away from my kids. So I'll probably run somewhere by myself.
Very good. Greg?
My wife is currently in her 3rd trimester of pregnancy and wants to get out of the house.
Oh, congratulations.
So we're looking forward to just being able to get some sunshine.
Very good. Alex?
Yeah, similar. Just get outside, maybe go to brunch, all those little things you miss when you're at home all day long.
Yeah. Steve?
I'll probably go to one of the 10 or 12 breweries in Missoula and see if they still know how to brew beer.
Oh, just one? One of the 10 or 12? Scott, what about you?
Oh, I'm looking forward to going in and having dinner on Sunday with parents, elderly parents. It's been really isolating for them, and I think very tough. So that'll be a happy evening.
Oh, wonderful. Aparna?
I think the same. I think all grandparents are missing the grandkids, and aunts and uncles and nieces and nephews and things. So obviously having friends over for dinner and things, but I'm very much looking forward to kind of seeing family in person again.
And Sharon?
Yeah. So I've got a toddler that is just like wanting to get to the park. So probably take him to the park and then do what Steve's doing and go check out some local breweries, make sure they still know what they're doing.
Steve, I feel like we're all going to take a road trip to Montana and just join you at the breweries. And my final question is, you know, there's been so much talk about retiring the handshake. So if I could ask everybody what you think your new handshake will look like, funny or normal, what it would look like if people want to share. My 16-year-old son says this is going to be his new handshake. And Angela, we'll start with you. How will you replace your handshake?
I'm good with the good air high five, you know? Yeah, maybe with a jump.
Air high five, okay. Andrea?
I think someone else said it earlier, but I am a very affectionate person. I'm saying the hug and some touch. We've been testing out the foot five in our house, so we might employ that.
You need good balance for that. Greg, what about you?
With all respect to Dr. Fauci, I'm a traditionalist. I need to shake those hands. Whether it's with a glove or what, we'll figure it out, but I still can't pull myself away.
Oh my goodness. Alex?
I'm pretty particular to the elbow bump.
Elbow bump, okay, got it. Steve?
I like the finger guns and the spinal tap, rock and roll.
Got it. Scott, what about you?
So I like Aparna said, I'm really kind of so deprived in hugs, as Andrea said. I may just go all in and just start hugging everyone for a month or so until I recoup my hug level. So
The people who are hug averse, they'll see you coming and say, "We got to get out of here." Bring it in. That's gonna be yours. Aparna, you shared yours, Sharon?
Well, my anecdote of my 6-year-old, the week the schools hadn't shut down yet, but the schools had already started not doing their morning handshake when they were walking into school too. And you know, in the Indian culture, we greet each other with like a namaste, which is a very common. So my 6-year-old came home from school that day and was like, "They're doing like my grandparents do to everyone." It's like very confused.
That's awesome.
Their cultural greeting was now being adopted at school. So
That's awesome. And Sharon?
Yeah, I'm good with like a wave, maybe a peace sign, and like a hello.
Yeah.
Yeah.
It's so funny because everyone's going to be doing different things. I wonder if like we're going to be kicking each other, elbowing each other, like missing and hitting the top of the head. But one way or another, I think that a lot of things are going to change coming out of this COVID-19 situation. Change for the better, change for the different. And it's challenged us in so many ways with everything that all of us do for living, for passions, just in our everyday life. So again, you know, there's times I started out with this hashtag that was like every time something terrible, but I would say hashtag COVID-19 because it was like because of it. Then I started posting wonderful things like in the middle of the day, having a peanut butter and jelly sandwich with my little one playing Go Fish. And I started saying hashtag thank you COVID-19. So I do think that there's going to be so many opportunities for us to find those silver linings, but not even just silver linings, but just find those new ways that we have to connect with each other. And that's really what this town hall has been about, connecting resources and people, connecting opportunities for us to all help each other through. And so I thank every one of you for everything that you're doing every day, those lives better. And I look forward to seeing you out there in the world with whatever form of handshake or hug, Scott, that we give. So thank you again for your time. And please note that after this, we'll be posting, share it out with people that you think it's going to matter to, and look forward to seeing you again.